And this is cardiovascular system, the heart, part B. So this is going to be about regulation. Okay, so it's the only organ in your body that can actually excite itself. So your basic heart rate is determined by your pacemaker. The pacemaker is actually more nerve-like. So you have a bundle of these nerve-like fibers that can, at a regular interval, fire an electric discharge. They fire an action potential. And as you electrically discharge through the pacemaker, the electrical discharge can then go down the cell membrane of the cardiac cells, very similar to what happens with skeletal muscle cells. And they will then respond by contracting. And the timing of this is milliseconds. So it's so fast. It doesn't seem to be as fast as it is, but to have that electrical discharge of a few cells spread throughout all of the cardiac cells in the upper chamber and in the lower chamber is quite a feat. And that is how you get the coordinated beat of the upper atria first, and then the coordinated beat of the lower ventricles. And when we talk about the contraction portion, we are talking about systole, because systole contraction is the movement of the blood either through the chambers of the heart or into the arteries. The diastole, the relaxation part of the heart, is absolutely essential to make a very effective pump as well, because when you have the relaxation of the cardiac muscle cells, that allows the chambers to expand and fill with blood. So you have to have both. You have to have a powerful contraction followed by a powerful relaxation. The contraction moves the blood that has accumulated because of diastole. So diastole, in a way, comes first and then systole comes second. You fill the chambers and then you empty them. And the pacemaker is going to set that in place. So if I have a resting heart rate of 90 beats per minute, and that means that my pacemaker fires 90 times per minute. And this is showing you where it is. You actually have a primary and a secondary pacemaker. Your primary pacemaker, which sets the rhythm, is your sinoatrial node. And that will discharge automatically from the time it develops in the fetus until the day you die. It's going to discharge. So but the whole thing is that the upper chambers, the atria, they're fairly small when you look at them, and they don't have half the number of myocardial cells that the ventricles do. So when they fire, you're going to have the atria contract first, but then that is going to be picked up by a second pacemaker, this atrioventricular node right here, and that is going to be more complicated in that the AV node is going to have the electricity go down the septum, which separates the right and left side of the heart, into your bundle of His, it's called. And then it's going to go to the right and left, called bundle branches. And then the Purkinje fibers, named after the guy who discovered them, is going to actually go deep into the ventricles so that every single solitary myocardial cell in the ventricles get electrically stimulated pretty much at the same time, and then they will contract very forcefully. So you're going to have your atrial do systole first and then diastole, and then during atrial diastole, the ventricles will do systole and then relax and do diastole, all controlled by the pacemaker. Now, do you have the ability to either speed up your heart rate or to slow it down? The answer is yes, yes. And that's going to be under the control of your cardiovascular control center in the medulla oblongata, that lovely mass in the back of your head and near your neck. And the medulla oblongata is going to pick up on signals. These are going to be sensory neurons that pick up on heart rate, stroke volume, how the heart is firing, how the heart is pumping. And then that information is then going to be analyzed by the medulla, and it has two responses. Your heart is under the autonomic nervous system. I don't have to think about my heart beating, it just does. And that's your autonomic nervous system. It's going to have a sympathetic and a parasympathetic division to that. Sympathetic tends to be about speeding things up, and parasympathetic tends to be about slowing things down. And that's the way it works with the heart. So that if you need to have your heart rate, your stroke volume, remember stroke volume is the amount of blood pumped every time the ventricles do systole, and heart rate is obviously how many beats per minute. So if you need to have those two sped up, then there are these sympathetic cardiac nerves that come out of the medulla, and they are going to branch. One is going to branch to the pacemaker sinoatrial node, and when it fires when it fires norepinephrine or adrenaline, that is going to speed up the pacemaker's firing, so you have an increase in heart rate. Now notice the other branch. The other branch goes right into the ventricular area, so that you'd get a really forceful contraction. So your stroke volume would go up as well as your heart rate. Now, if you wanted to slow things down, then that is going to be the parasympathetic or the vagus nerve. And that is mainly going to be going down into the pacemaker as well. Now, it is going to release acetylcholine. And acetylcholine will slow down the pacemaker firing. And you also are going to slow down or have the contraction be less forceful. As you see, it branches as well. So if you want to regulate your heart rate, sympathetic cardiac is going to speed everything up, heart rate, stroke volume. If you want to slow things down, parasympathetic vagus is going to slow down the pacemaker firing and the contraction of the ventricles. So your heart rate and stroke volume go down. So you do have this ability to either accelerate or break the pacemaker and increase the heart rate or decrease the heart rate, and in addition stroke volume. So you can either speed up the heart or slow it down. All right, now we have the ECGs, the electrocardiograms, and that is going to be a microscopic view of how the pacemaker works, how the pacemaker generates its action potential, gets the atrias to contract first and then the ventricles. And if you looked at one cycle of the heart, both the systole and diastole, you would see a typical ECG tracing. And I'm going to show you a picture in a second, but for some reason they decided to go to the middle of the alphabet, and so you have a P, you have a Q, RS, and you have a T. So P is going to be a wave that corresponds to the depolarization of the sinoatrial node. And then you are going to have a QRS complex. Now, the reason for the three of them in the complex, it's very complicated. And when you have your atria with your P wave depolarize, they're tiny. But when you have your ventricles depolarized and your QRS, that's huge. And since you either like double or triple the size when you go from P wave, atria, QRS to ventricular, the reason why it's complicated is you have to get to so many more cells. But indeed, that QRS will signal depolarization of the ventricles. P waves for the atria, QRS for the ventricles. Now, hidden in this QRS complex is going to be a repolarization of the atria. You don't see it as much, or actually don't see it at all, unless you're an expert at reading ECGs, but indeed it is bundled into that QRS complex. So as your atria depolarize in the P wave, then the QRS is going to repolarize, but because the massive discharge of the ventricles and the QRS complex being so complicated, it's hidden. Okay, and then the last is the T wave, and the T wave corresponds to the repolarization of the ventricles. And away we go. So this is a normal ECG. So this is just showing you in the heart where things are being generated. And over here, here's your P wave, your QRS complex, and then your T wave. So you have your atrial P wave, atrial depolarization, P wave. QRS is hidden in that is the atrial repolarization as well as the ventricular depolarization. And then the T wave, the last wave of the electrocardiogram, is the repolarization of the ventricles. And that brings us to cardiac cycle. Cardiac cycle is a way of understanding how the heart not only works as a pump, but ensures the unidirectional flow of blood. So you, in a healthy heart, and this is normal AMP, you are going to have a person who is going to be having the atria contract followed by the ventricles, and the movement of blood to the heart is going to be unidirectional. So systole is the contraction and diastole is the relaxation. Okay, so there are 4 stages of the cardiac cycle. Every book that I have looked at has a slightly different explanation of the cardiac cycle. So for this quiz, it's going to be this explanation, okay? I have read books that have 2 phases. I've read books with 3 phases. I've read books with 4 phases. I've read books with 5 or 6 phases. So for this quiz, it's going to be the 4 phases here. So the first phase, stage 1, is atrial and ventricular diastole. Very briefly, there is a moment in time when the atria and ventricular chambers are relaxed. And what you want to do when they're relaxed is you want to fill them. So what happens in stage 1 is those atrioventricular valves are going to open. Because there's a little bit of pressure higher above than below, and the atria fill, and some of that blood is going to trickle down into the ventricles. But when you get down to the ventricles, the semilunar valve is shut tight. And that has to do with the fact that the heart has just gone through a ventricular systole, and so there's more pressure in the arteries than there is in the chamber. So that's stage 1. Stage 2 is called atrial systole. So your atria actually now are going to contract, and then once they contract, they're going to force that blood into the ventricle. Your AV valve obviously stays open, but your semilunar valves are still shut because the pressure is still not greater than the blood in the arteries. But then comes stage 3, the most confusing of all stages. And the name is confusing, isovolumetric contraction. So let me kind of talk this through. There comes a period of time after atrial systole that you've got blood in your ventricles, and you have a situation where the ventricular systole is so enormous that they kind of divided it into like early systole, late systole. But instead of calling it early systole, they call it isovolumetric contraction, just to confuse you. And then the late systole will be called ventricular systole. But in the stage 3, which is like the early stages of the ventricle starting to contract, you have this very weird period of time when the atrioventricular valve is going to snap shut because the ventricles are starting to contract. So they're starting to get pressure. And this pressurization of the ventricles will mean that the AV valve is going to snap shut in order to prevent backflow. But the semilunar valves are still shut. And it's kind of hard to believe that the pressure in the arteries is still a little bit higher than the ventricle, but that's the way it is. So you have a situation where for a moment in time, the upper valves are shut, the lower valves are shut, and blood is trapped. It can't go up, it can't go down. This actually becomes useful when cardiologists want to determine how effective the heart is, especially the ventricles, as far as holding on to that blood before it is ejected in the next stage. So ISO, the same volume. So in early ventricular contraction, there is a time when the volume of blood in the ventricle is the same because it can't go up, it cannot go up, it cannot go down. So it's the same. So we actually name it, of course. So we are going to be calling it isovolumetric contraction, and the amount of blood that's trapped in there is called the end diastolic volume. In other words, the volume that's in the ventricle after the ventricle has relaxed, or another way of looking at it would be once the atria has pushed the blood into the ventricle, it's the beginning of their diastole. No matter how you want to reference it, what happens in the very beginning of ventricular systole is that will be a certain amount of blood that is present that is not going to change in volume until the next stage. And the next stage is stage 4, ventricular systole, or the late events of contraction, the power stroke. The cardiac cycle is the same on the right and the left. I tend to emphasize the left more because that is delivering blood to all cells of the body except the lungs. So it has to have an incredible forceful contraction. And let me go back. I have this trigger finger that gets me a little ahead of it. All right, so what's now going to happen is that the ventricles are in the late stages of contraction, full-blown power stroke. And so finally, the semilunar valves are going to open. Now, the atrioventricular valves above stay shut. The semilunar is open, so now your ventricles can do their power stroke, their systole, and they can push blood into the right side, pulmonary artery, the left side, the aorta. And you don't get regurgitation, you get the blood pumped by the heart into the arteries, which continue to flow so that every cell in the body can get oxygen and glucose be delivered. Okay, so that is the cardiac cycle. All right, so here's the diagram from hell, or sometimes I call these diagrams kitchen sink diagrams because they have every possible permutations on a theme. I tend to find them confusing. I'm never going to show you this on the quiz and say interpret this, but some people really love this diagram. So here goes. This is showing you your electrocardiogram. This is showing you your lub-dub, your heart sounds, which is caused by the valves snapping shut. This is showing you what is happening as far as the pressure that is in the chambers of the heart. This is showing you the ventricular cardiac cycle, especially the very, very end, where you have the end diastolic volume, then you have the stroke volume, the amount of blood that's forced out of the heart when it contracts. This a little bit of blood that is left behind. That's called the end systolic volume. And then this shows what the valves are doing, and this shows how the heart works. So if that is helpful to you, great. Otherwise, no worries. So, cardiac output. What do I want you to know? I want you to know the definition. So, cardiac output, the amount of blood pumped by the ventricle in 1 minute. So, your heart's pumping for a minute, and it's then you can then measure the heart rate and the stroke volume, and that's the cardiac output. So it's the product of the heart rate, how fast the heart is pumping, and the stroke volume, how much blood is ejected per beat. So HR's heart rate, number of heartbeats per minute, SV is stroke volume, the amount of blood pumped out by a ventricle with each beat. So collectively, the heart rate and stroke volume in a minute will pump out an enormous amount of blood, and that amount of blood is called the cardiac output. That becomes important when you get to regulation. All right, so we talked a little bit about regulation when we talked about the medulla and how it can affect heart rate and stroke volume. And there's another term that I do want to talk to you about. All right. Actually, I think I'm going to talk about this first. Okay, I'm going to talk about Frank Starling's law of the heart first, and then I'm going to go back. Two guys, Frank and Starling, did some terrible experiments on dogs. And what they discovered is that if you take a heart of a dog and you put it on a platform and you alter the height, then you can, because the heart is able to excite itself, so as long or until the dog's heart on this platform filled with tubes, as long as it has enough oxygen and glucose, it's going to be able to continue to pump, even outside of the dog. And from that, they were able to find out their law of the heart. So I am going to explain it in one way, and then I'll get into preload and afterload. If you end up returning more blood to the heart than usual, you will stretch the ventricles. And we tend not to think about the elasticity of the heart, but the heart is quite elastic. Yes, it has obviously millions and billions and gazillions cardiac muscle cells, but between them they have a lot of elastic fibers. You want the heart to be elastic, so you want it to contract and then to recoil and relax and so forth and so on. So it becomes very important to have a little bit of stretch. So what Frank and Starling learned from the dog experiments is that if you put more blood back than larger than normal, it will stretch the heart because of the elastic nature of the heart. And just as you stretch an elastic and you let go of it and you get a good rebound, a snapback, the same thing is going to happen to the heart. It will snap back more forcefully. So the stroke volume will be larger. So what Frank Starling is trying to get at is that if there is more blood returned to the heart and the heart ventricles stretch, you're going to do not only get the amount of blood ejected because of the contraction of the heart, you're going to have a little bit more blood be ejected because of the elastic snapback of the heart because you've stretched it. So what I am now going, now that becomes important because of exercise and things of that nature. So I'm going to go back to the other slide, which goes into preload and afterload, which is something that can be measured, and it does tell you a fair amount about a healthy heart and so forth and so on. And then when you take patho, you can figure out, or they'll discuss pathological preloads and afterloads. So the preload, the amount of the ventricles that are stretched by contain blood. So Frank Starling found that you can manipulate that. You can have a greater preload, a greater stretch. And the contractility is one factor, but the stretch factor of Frank Starling's law of the heart comes into consideration if the preload is quite large. Then the afterload, you have that stretching for the preload, the afterload. It's the back pressure exerted by blood in the large arteries leaving the heart. And that sounds like a whole bunch of gobbledygook, but what happens is that you've got the stretch, and then you've got the cells contracting and the stretch snap back, and that is pushing blood into your arteries. Now the arteries are highly pressurized because they have all this blood that's just pumped into them. And depending on how much blood you pumped into them, there is going to be some resistance to the blood flowing into those arteries. And now once the valves shut, that afterload or back pressure is something that the heart will have to overcome the next beat, because blood moves high to low pressure. And let me show you a diagram that may help. Here we go. So here we go. Preload is right here. Preload is depending on how much the volume of blood that you push into those ventricles, you will either have a little or a lot of stretch. If the volume is a lot, there'll be a lot of stretch. So that's going to increase your preload or your stretching. And then your afterload is over here. So that's going to be that elastic recoil, but it's also going to be the fact that you've pushed the blood into your arteries, into your pulmonary artery, into your aorta, and that pressure will have to be overcome the next time the heart beats. It's not a problem with a normal heart. Your preload and your afterload should be matched so that the heart isn't in a situation where it has to work harder. When you take patho and you start to get into things like hypertension, and I'm not going to have this on the quiz, but this is the reason why I would probably have a definition that I would want you to match up as far as preload and afterload go, because when patho comes along, you're going to have situations where people can have aging hearts, and or that they could have undiagnosed or non-compliant hypertension. And if you have hypertension, let's say in the aorta over a long period of time, then that pressure is going to go abnormally high. And afterload is going to be an issue. And the heart is going to then have to work harder because there's more pressure due to the hypertension. And then that heart will start to bulk up like your skeletal muscles do, but that will reduce the chamber and so forth and so on. So very often people with undiagnosed or non-compliant hypertension 10 years down the road are going to have some pretty severe heart problems. And that has a lot to do with the preload and afterload. You could have congestive heart failure, and an 85-year-old have a very old saggy heart, and they're having a problem with preload, and that could also have a problem with afterload. Hypertension could be another issue around afterload. So that's the reason why the concept of preload and Frank Starling's law of the heart and the concept of afterload is important, not so much with normal. It all should be matched. But with pathophysiology, with cardiomyopathies, with hypertension, it is going to be an issue. And the nice thing is that when you start to define the finer stages and the finer levels of regulation, that's when you can help the patient, especially with certain drugs, etc., to get the heart and the blood vessels to be in a much more functional state than they were originally with the pathologies. So having said that, that is the end. Oh, almost the end. Sorry, I've already done this. So it's almost the end. I've already gone into sympathetic and parasympathetic. Okay, this is the end, because I put this in as a overview. I am not going to use this diagram on the quiz. But if you are dying of curiosity and you want to know how all the parts work together and how they regulate one another and work together to have everything match, this is your diagram. So this is the overview of factors involved in the regulation of cardiac output. Ta-ta! The things that I've talked about during this lecture, that's it. That's the only thing that you're going to be responsible for. Now we're at the end. All right, so the next time I see you, we're going to be talking about blood vessels. So I will see you soon.